Hello, everyone, and welcome back to session 2 of the Completed Life March Symposium. My name is Sarah Kiskadden-Bechtel, and I'm the Program Director at the Completed Life Initiative. And I will be your host today as we explore the topic of unprecedented, multifaceted suffering in the context of serious illness. Today, I have the honor of introducing our panelists today, Chaplain Linda Golding and Dr. Brent Kious. A little bit about Dr. Kious. He is the Assistant Professor of Psychiatry, Adjunct Professor in the Program in Medical Ethics and Humanities in the Department of Internal Medicine, and Adjunct Professor in the Department of Philosophy at the University of Utah. His research in bioethics has encompassed the role of values in psychiatric diagnoses and the ethics of informed consent, and his current work focuses on the assessment of suffering at the end of life. He earned his MD and PhD in philosophy at the University of California, Los Angeles in 2011. He completed residency in psychiatry at the University of Utah, where he was chief resident in psychiatry. And he is a 2023 Greenwald Foundation faculty scholar in bioethics. Here's Dr. Kious' photo. Chaplain Linda Golding earned her master's in Jewish studies and the certificate in pastoral care and counseling from the Jewish Theological Seminary in New York City, and is a board certified chaplain through the Association of Professional Chaplains. Following a substantial career working with classical music composers, Professor Golding changed paths and serves as chaplain at New York Presbyterian Columbia University Medical Center and coordinator of pastoral services at Milstein Hospital. She is the chaplain member of the Hospital Ethics Committee and Organ Donor Council. She leads didactics on ambiguous loss, spiritual pain, and pastoral care to non-responsive patients, and serves as a preceptor for medical student clerkships. She also runs reflection rounds with nurses and a wellness group for neurology residents, and is an adjunct professor in the bioethics program at Columbia University, where she teaches pastoral care and ethics. Linda and Brent, it's an honor to have you here today, and welcome to our audience. Thank you so much for coming back for session 2 of our March Symposium. Without further ado, I'll turn over the baton to Professor and Dr. Brent Kious, who will get started with his presentation.
Thanks very much, Sarah. So I'm just going to pull up my slides a bit. Okay, so I think everybody can probably see that. Sarah, look okay? Great. So like Sarah said, I am a psychiatrist, and I thought it would be interesting today in conversation with Linda, who has a different perspective on these issues than I do to some extent, to think about the various ways that suffering can be complicated and what medicine and allied fields can do about that suffering when it's complicated and really intractable. And since I'm a psychiatrist, I'm interested in what psychiatry can do about suffering. So today I'm going to talk about how we typically approach suffering in psychiatric practice, what it's like. And then I'm going to give a fairly extended presentation of a case, a young woman I cared for recently who had multifaceted suffering in several dimensions. I think that'll illustrate how suffering can be multi-layered and reflexive and self-perpetuating. And then I think it raises some hard questions about what we can actually do. So these are my disclosures. I really don't have any conflicts of interest that are relevant to this presentation. So I think in psychiatry, at least at a first gloss, suffering can come in a couple of different forms. One is the psychiatric illnesses that we care for all the time can cause suffering all by themselves. It's unpleasant to be depressed, anxious, terrified, traumatized, to have delusions and hallucinations. At least it is some of the time. I think not all psychiatric disorders, even though they are disorders, cause subjective suffering among the people they afflict. Another way that psychiatric disorders can cause suffering, at least, initially, is by directly undermining people's resilience. Part of what makes for suffering is having a maladaptive or distressed response to difficult circumstances. And unfortunately, when people are depressed, for example, their ability to tolerate distress and difficult circumstances might thereby be reduced. So I've kind of come to think of psychiatry in the years that I've been practicing, and actually as a result of thinking about it in the context of some of these talks here at CLI, as a palliative specialty. Frankly, there's not a lot we can do as psychiatrists to actually cure the underlying disorders that we treat. And so most of what we can offer patients are interventions that reduce their symptoms, often only temporarily. You might think that psychotherapy can improve the disorder itself. And maybe that's true for things like anxiety disorders treated with cognitive behavioral therapy, where that can modify maladaptive patterns of thinking over time. But I think a lot of therapy is primarily aimed at reducing suffering and palliating a person's symptoms by promoting acceptance. And that's exemplified in treatments like dialectical behavioral therapy, which is relevant to the case I'll bring up. So I think altogether, those approaches are helpful, 95% of the time, a lot of the time. Unfortunately, there's a 5% group that isn't really sufficiently helped by them, and I wonder what we can say about them. So let's consider this case. It's a woman I cared for recently. She was only released from the hospital about a week ago. So let's call her Stephanie. She's a 30-year-old woman with a complex medical and psychiatric history who gets admitted to our medical psychiatric unit here at the university for suicidal ideation. Her psychiatric history consists of major depressive disorder, borderline personality disorder, and what we call polysubstance dependence, which basically means she's been addicted to lots of things, including opioids, alcohol, methamphetamine, and cannabis, though she's actually been sober from alcohol and methamphetamine for a few years. Her medical history is pretty fraught. She developed transverse myelitis, which is an injury of the spinal cord due to West Nile virus infection, and that made her paraplegic. And so for the past 5 years, basically, she has been wheelchair bound and requires an indwelling urinary catheter and a colostomy and lots of other care from nurses to avoid things like pressure sores, etc. So when she comes into the hospital, she tells my colleague, the admitting psychiatrist, that her suicidal ideation has been getting much worse. She has it kind of at baseline because of severe, unrelenting, and chronic neuropathic pain that's due to her spinal cord injury. It's sort of like she has phantom limb syndrome, except it's the whole lower half of her body. She rates her pain as 8 to 9 out of 10. And it's this bad despite the fact that she's been taking extremely high doses of oxycodone, over 100 milligrams a day, gabapentin, pregabalin, tizanidine, acetaminophen, ibuprofen, duloxetine, and a couple of other things. She says to us, "I'm only 30. I don't want to live with this pain until I'm 50. I don't think it's just her pain that is prompting her suicidal ideation. For one thing, her social situation is extremely complicated and messy. She was recently evicted from the third nursing home in which she'd been living for the past 5 years since her illness started. And as far as I can tell, that eviction happened because she was having frequent conflicts with the nursing staff at the facility that led her to have increased stress and then increased suicidal ideation, which eventuated in a suicide attempt. After that suicide attempt, she was admitted to another psychiatric facility nearby, not ours. And when they tried to discharge her back to the nursing home said no thanks. So the other facility essentially just discharged her to the street. She ended up living in a halfway house that was run by somebody who she knew from the days when she was using methamphetamine heavily. She doesn't have any family support at all. She's divorced, she's estranged from her children, and her other family have asked her not to contact them, especially her father and her brothers. She hasn't seen her mother for over a decade. But it's not like her family is a good source of support anyway. Her father sexually abused her until she was 13. And the last time she spoke with her oldest brother, he said, if I was in your place, I would just kill myself. So we're trying desperately to find a place for her to go because she's still effectively homeless and really can't make it on the streets, of course. Our social worker is trying really hard to find other options for her to live. But at the time I've written this, it's called 8 nursing homes, and all of them have refused her, essentially because of her psychiatric history and the liability they associate with that. She's a very difficult patient. Every day on the unit, there's some kind of new crisis. There's always a new conflict with the nurses or with me or with my medical student or resident. And it's typically prompted by some kind of perceived mistreatment related to seemingly small matters, like the fact that she didn't get her oxycodone exactly when she wanted it. One day she exhibits an elevated temperature of 99.9, which is not a fever, but she was convinced that it was a fever and insisted that we do all manner of things to work it up, which I thought was medically inappropriate. So when we have these kinds of conflicts, it results in verbal altercations, mostly on the part of the patient, but not always. That ends up being punctuated by profanities from the patient, then threats that she'll attempt suicide, then demands that she be discharged or get a different doctor or other members of the care team. And then ultimately, she kind of collapses into this awful state of remorse, shame, and catatonic withdrawal where she does very little other than lay in bed and take medications. And in those quiescent periods, she expresses deep self-loathing and wonders why she always screws up everything in her life and what the point of it all is. And just to make it very clear, we're trying our best to make things better for her, but not making a lot of headway. Her pain continues to be high, 8 to 9 out of 10 most of the time, despite her aggressive outpatient regimen and then all the things we do on the inpatient unit to help. We call the inpatient pain service, and then review that she's previously had an intrathecal pain pump. She's had ketamine infusions. She's used lots of cannabis, and she's had all manner of topical remedies with really no response. Likewise, her psychiatric conditions haven't gotten much better, even though she's taken antidepressants, mood stabilizers like lithium and Depakote, multiple antipsychotic agents, which can stabilize emotional ability, and had extensive therapy for her borderline personality disorder, which might be the linchpin of all of her other symptoms. She'd had extensive outpatient therapy, including DBT, which is really the gold standard treatment. On our unit, she's still receiving daily individual therapy from me when it's feasible, and group therapy essentially continuously throughout the day. Still no headway. So I think it's clear that Stephanie is suffering and probably suffering severely. I think to understand how she's suffering and why she's suffering, it helps to have a definition of what suffering is. And I like Cassell's definition from the 80s. So Cassell said that suffering is a state of severe distress that arises in response to a threat to the integrity of the person. And I think that fits Stephanie really well. Distress is basically any negative emotional or perhaps phenomenological state. And a person is constituted by a multitude of dimensions, different goals, values, relationships, a history, the body, et cetera, et cetera, et cetera. So Stephanie's suffering is extreme. She has a great deal of distress, and she's also experiencing threats to the person at multiple levels, essentially all the levels you can imagine. At the bottom of all this, her person, her very identity, is itself fragile. As a person, she's not doing very well. So it's clear that Stephanie has very severe physical pain that causes emotional distress. She has reduced physical functioning, which makes her less capable of doing things that matter to her. She is socially isolated and abandoned. She is having severe anxiety, anger, depression, sadness. She is racked by self-hate. She frequently wonders, what's the point of all this? Why am I getting all of this care only to eke out this miserable existence which isn't satisfying to me or to anyone else. And in my darker moments in caring for her, I sometimes wonder the same thing. And I think she's probably having suffering at a spiritual level too. But I'm going to defer that to Linda because I think she has a lot more to say about it. Sarah suggested that we think a little bit about how suffering and autonomy relate to each other and whether threats to autonomy can comprise a sort of suffering. I think in one way, Stephanie is actually autonomous. She seems to retain most of her decision-making capacity. She's rational. She's actually really smart. Maybe she's not fully autonomous because her emotions and her preferences are so extremely unstable. What she wants in the morning is not going to be the same as what she wants in the afternoon. So even if her autonomy doesn't, or the threats to her autonomy may not constitute suffering for her, I think it certainly contributes indirectly. She doesn't know who she is, but she wishes that she knew who she was. She has inconsistent desires that make it impossible for her to achieve anything that matters to her. And her impoverished sense of self means that she is vulnerable to other people on whom she relies to hold her together and really tell her who she is or who she's supposed to be. Her relationships with other people are complicated, and I think the suffering that she experiences makes those relationships worse, and then that in turn worsens her suffering. She rejects other people because they cause pain to her, often through no fault of their own. And then others reject her in turn because she causes pain to them. It's very difficult being her doctor because, frankly, she makes me feel incompetent a lot of the time. There's not a lot I feel like I can do to help her. As a result of that cycle, she's deprived of the very thing that might ultimately alleviate her suffering the most, human connection. And so her suffering has just gotten worse and worse and worse. A third dimension is that she is deeply institutionalized. Like I said, she's been living in a nursing home for the last 5 years. She's only 30, so this started in the prime of her life when she was 25. She's physically dependent on others. If her colostomy bag starts leaking while she's in an institution like my psychiatric hospital, she can't actually fix it herself. She has to ask a nurse to do it and then has to wait on them for a time when it's convenient and has to endure their irritation and that extra demand. I think organizations ultimately end up seeing her as a set of problems rather than a person. And frankly, because she's been in institutions for so long, for so much of her life, she's had a difficult time developing aspects of the self that might hold her together and constitute her identity. So what do we do? Well, I can't help but wonder whether medical aid in dying would be appropriate for someone like Stephanie. And although she didn't ask, I've had patients who are in a similar situation ask this question. I'm not in principle opposed to the idea that medical aid in dying could sometimes be appropriate for people with severe and treatment refractory psychiatric illness. But I'm pretty convinced it wouldn't be okay for Stephanie, largely because her autonomy is compromised by her acute distress. There's no fact of the matter about what she really wants. And I don't think she would be able to think clearly about that kind of emotionally fraught question. So I'm at a loss. And then I wonder, at what point must we, as healthcare providers, as other kinds of caregivers, admit that there's suffering we can't touch? And I want to point out that this might be harder for patients like Stephanie, where their illness is non-terminal. She could live another 30 or 40 or 50 years and continue to deal with these symptoms. And so all of us will have to deal with these symptoms and constantly be faced by the question of what we can do best to help her. When we realize there's not a lot that we can do, how do we accept that? How do we accept it with anything like grace? And I'm hoping we can maybe talk about answers to that question today. So I'll turn it over to Linda now. Thank
you. Brent, thank you. That's a really, I a really beautiful presentation of a pretty terrible situation. I'm trying to work out which are my slides here. I think this is it. And although we talked about this before and we looked at each other's slides, I'm struck by many things that I didn't think about before. So I will do a little bit of elaborating on what you're going to see, and then I think we can have a really intriguing conversation about this. So really wonderful starting. So I'm looking at suffering as part of the human condition. And that's where I want to take us. And as you're listening, think back to the case that Brent presented and see what lands for you, okay? So what makes up the human condition, right? Now, we all have a different view on this. So I'm going to try and take this from the view of a chaplain. And let me say right up front that the way I describe my chaplaincy is that I help people remember who they are when they're not in these terrible situations, when it's not a patient in a hospital or an institution or family that's having to visit, having their lives upended, and also for staff, this remembering who we are when we're not in this situation. Okay, so we have these various characteristics that are part of us. We don't know if they're nature or nurture. They develop over time. They respond to our circumstances. And we then respond to these things in ourselves, to our characteristics that other people tell us they like or they don't like, right? That evoke certain types of responses in other people. We seem to have this temperament that we're born with. I'd like to think that parts of it are hardwired and parts of it are flexible. But each of us tends to have a general outlook on life, even in really challenging situations. We may have to pull it back out of ourselves, but there is a basic place that most of us start. Sometimes it gets ripped from us. And I would argue that that's actually a piece of what we're seeing with Stephanie, based on the family story and all these things that were done to her, including the West Nile virus. Like, she didn't control that choice and the result of it, right? So this notion of having things torn from us can also be part of our temperament. Spirituality, one of my favorite moments is always walking into a room in the hospital saying that I'm a chaplain, I'm here to see how you're managing today, and somebody says, I'm fine, thanks, I'm an atheist, because they think that's going to make me go away. And I'm like, fantastic, tell me, have you always been, like, how did you decide that, right? I mean, somebody makes a decision in their life, it's a big decision, and I'm curious. But I also have a very broad definition of spirituality, which is, I think it's that which gives each of us our greatest experience of being human today, because it might change tomorrow, might even change this evening, right? Our greatest experience of being human. So this is another place where things can get messy, things can get torn from us, things can be taken out of our range of experience. And resilience. Right? These are characteristics we're mostly wired. We mostly come with this package of things. And we can always increase and decrease, but there's certain things that are just from my experience as a chaplain and having worked with artists and musicians for such a long time, it comes with us. And resilience, and I think, again, in Stephanie's case, perhaps this is particularly relevant, resilience meaning the process of adapting, not the on-off switch, right? The process of adapting well to stressful circumstances, right? We all know how to adapt poorly, right? Like, we don't need to learn how to do that. But the process of adapting well, so a continuum, right, that we could be on. And I'm thinking now, like, that maybe Stephanie isn't even on a continuum. Or maybe it is a continuum, but it's a continuum that's at such a place that it's that 5% that where we can't touch it. Like we can't see the edges of that continuum. Right. Key events in our lives, education, relationships, work, committed partnership, parenthood, right? These are markers, right? And life cycle events. Birth, coming of age, entry to adulthood, just about every culture has something around that, around coming of age, entry to adulthood. Again, a very delicate place that can be torn from us easily. Rituals around partnership, how we make partnership, how we don't, right? Marriages, all kinds of things. What are those actual rituals? And I think, although this is not exactly a marker, it's a long period aging. The process of aging is a marker. And I'm struck by the comment, Brent, that you offered from Stephanie that says, I don't want to live till I'm 50 with this kind of pain. And I thought to myself, 50, is that her place? Is that her spot? Does that have some kind of meaning for her? Right? And death, of course, is a life cycle marker. We're present. We may not be present in the way that we were through some of these others, but it's a life cycle marker. What tempers our experiences? Again, these things that we sort of come with, personality, resilience, also storytelling. How do we tell our story? How do we apply our histories to ourselves? So in some cases, that could be how we connect the dots, right? That sort of meaning making over our lifetimes. But it can also be somebody who says, well, I'm like this because, right? A cause and effect kind of thing. But, human beings are natural storytellers. This is just what we do, right? From ages ago when there was fire, right? And so it's a piece of connection. So just think about what happens if we can't tell a story, our story. If somebody else is always telling our story for us, which we've all experienced and witnessed, we're seeing it now in our world of pandemic and racial anguish and hate crimes and any number of other stressors, right? So storytelling is a critical piece of our human condition and its experience, and figuring out what to do with those stories, right? Emotions. Everybody's got a whole array of emotions. Brent and I probably both have emotion wheels and, like, what are the words, right? When I was in my training, I'm reasonably literate, but the only emotions I could come up with they were like 2 or 3 words. So I had to get a piece of paper that had 100 words of emotions on there so I could get a little more flexibility, right? Not everything was anxiety, right? That's my come from New York. So these are the ones that I like to look at: happy, sad, mad, scared, and powerful and peaceful. Not usually part of how we look at somebody, right? Is that person able to express their power in a meaningful way, not just as a cudgel, right? And peaceful. Where is the peace in there? Where could it be? Where might it have been? What was there before scared became such a major piece of the person's emotions, or how they define themselves, or tell their story, or how we in the medical chart tell their story, right? All right, so suffering. Suffering has a lot of definitions, and I have to say that I'm always, excuse me, mostly drawn to one that is considered, it's called archaic in the dictionary. And that one is the ability to tolerate, to withstand, to endure. It's a totally different way of looking at suffering. The ability to tolerate something, to abide it, to stand for it, stand with it, right? And that, I think, for me, the reason it's such a draw is because there's these questions of, well, what is suffering? Right? Is it an emotion? Not usually, right? It's usually set aside from an emotion. Is it a state of being? Well, if it's a state of being, does that mean that we have some autonomy over it, that we can shift our state of being in some way, or that somebody can help us, or that we allow somebody to help us shift our state of being? Going back to the storytelling and applying histories, is suffering the narrative that I tell you? Or is it the narrative that you tell about me? So some years ago, a psychotherapist colleague and I ran for some time a group for people who suffer from chronic pain. Nothing like what Stephanie is going through, right? But people who were suffering tremendously in their lives. They were tolerating it, and they were in pain, and they were trying to learn how to endure. And we worked together to find some place where spirituality and psychotherapy could actually make a difference. And where we got to was the power of discerning. Is this an emotion? Is it a state of being? Whose narrative am I telling? And at the end of it, I think probably their pain numbers were higher than when we started. We did a measurement. And my psychotherapist colleague was horrified, and I was thrilled because, from a spiritual point of view, it means the people were really present and they had begun to make some shifts in their state of being. Okay, what kind of suffering can there be? How do you maintain a personhood through illness, right? So I love Castle's article and his definitions. The disintegration of personhood, right? The pieces just falling apart. And some of the obvious ones, right? Dementia, psychological or psychiatric suffering, mental illness, any kind of disability, socioeconomic disparities and loss, right? Suffering is everywhere. And the reason I call this the human condition is because it is in every part of our lives. I think where we're trying to make some distinctions, and this is such an interesting place to have a conversation on this topic with a psychiatrist and a medical professional and an ethicist and philosopher like Brent, is how do we allow for this human condition, because we don't have any control over it, right? And how do we help construct or reconstruct personhood at such a severe time? And what part of suffering is a violation of autonomy? Is it a violation of autonomy? So the different kinds of suffering, I mean, these are just very beginnings, right? You will all have lots of other ways of expressing it. It's helpful to distinguish the kind of suffering that you're witnessing in order to increase your own awareness about helping people who face these elements of life, of elements of distress at the end of life, but also in their continuum of life, right? So is it really possible to build resilience as our life is coming to the end? As a chaplain, as somebody who's a spiritual caregiver, I would say yes. If we look at talking about resilience as the process of adapting well to challenging circumstances. So different kinds of suffering, different definitions of suffering. How is the person in front of us defining this state of being or this narrative? We have characteristics, we have structures we can work with, but what we don't know is really what the person will tell us and how deeply they will delve into that explanation, that storytelling. So I think this is our moment to jump in and see where we go. So where shall we start?
Well, I think, Linda, we had planned that we would pose a couple of questions to each other.
Indeed,
Right.
indeed. I just think I have different questions than I had prepared now that we've both, right? So that's why I'm like, I don't know, you go first, you know?
Well, one thing I wonder about is, you have illustrated the importance of narrative and the stories that we tell ourselves in constituting suffering, but also probably in constituting resilience. And I wonder what you think about how that could be brought to bear on a situation like Stephanie's.
Yeah,
How could we reformat her narrative?
right.
What do you think?
Yeah, yeah. So the thing that really struck me, um, listening to the case this time in this way, um, is the unresolvable loss in which she is living, right? I mean, you call it ambiguous loss or unresolvable loss. Like there is not a way out, right? It's so layered. It so predates the physical ailments, right? If her father was abusing her until she was 13, we don't even know where that began, right?
Right.
Um, the family information that you described. If she has children, she must have had them extremely young, right? So all of these layers, and uh, there's no way really, I think, to resolve it. There is a way to get through it. And I think that's what I would be looking for is the losses are there. Let's pick each one up maybe and look at it. The image that came to my mind was the sort of the seashells, that we see. You pick them up and you look at them, and some of them are incredibly perfect and whole, and some of them are picked apart in the most fascinating ways, and we don't really know exactly how that happened, right? But the idea of helping her reformat, right? Let's just imagine she was willing to reformat, right? We don't know. She might be, we don't know. Like, where would she start? What parts would she rewrite? Where would that give her some relief from this unremitting collection of sort of stacked difficulties? And we don't know, right? I'm very taken by what you said about we can palliate the symptoms for a short period of time. It's the same thing in pastoral care. My sense is that, if somebody has had a minute or two of relief, I'm really happy about that, right? Because for that moment, they've been able to shift that state of being. And I think that's what we're looking at. Somebody who is in every way appears to be intractable, and yet maybe there's a different story she'd like to tell. My dad slid rapidly from early stage dementia into sort of middle to late. And by the time I noticed it, he was in middle to late for various reasons. Noticing, people cover dementia, and we live across the country from each other. And just as an example of this, he told stories about our lives together and our family that were completely unrelated to the stories that I grew up with. And I realized, right? I realized as the daughter, I had some choices here, right? Very hard to be a chaplain and a daughter at the same time. But what I realized is he has rewritten the narrative, and so can I. Because the content didn't matter, the connection mattered. And so that's what I'm thinking about in terms of Stephanie. Like, you can't fix her. I mean, I can't fix her, right?
No.
But is there a place that you could help her pry open that would help her get through, that changes the format? I love that idea of changing the format of her narrative. And are we invested in the content of the narrative as providers? I mean, as a psychiatrist, are you invested in the content? Is that, I mean, you want to make sure she's safe, obviously, but
Right.
in other than the safety part, I wonder what your concerns are about the narrative that she tells now.
Yeah. So, I think a big part of my therapeutic work with her and the work that others had been doing at the same time was was in some ways aimed at helping her rewrite the story, reformat the narrative, to the extent that there's no changing her losses, all of the things that she's lost. There's no changing her recognition of that, right? In the way that maybe your father was able to just fundamentally change the actual facts on the ground.
Well,
But at times we would try to help her change her stance with respect to some of those losses, right?
uh-huh.
See how they were meaningful in some way.
Mm.
And I think there's also something that you see in work about trauma, especially, is changing your role in the story, right?
Mm.
So do you continue to think of yourself as a victim or as a survivor? And um, so that was the goal with
Mm.
Stephanie. Did we make headway on it? I'm not sure. You know, I think the other part of it is trying to help her gain a sense of what actually matters to her, so that by identifying those core values, and lots of different kinds of psychotherapy use this approach, we would enable her to identify small, practical, day-to-day steps that she could take to start building the kind of life that she might want for herself, right? The
Mm.
first step being figuring out what that life would actually be like given the constraints that she's facing.
Mm. Yeah, I think it would be fascinating if we could find a way to get the tools. We don't know what tools those would be for her, right? Um, to make that story. See, I find that I'm rarely concerned. I mean, this may be a fatal flaw, right? I am rarely concerned with the truth of the storytelling,
Hmm.
right? I am mostly concerned about the themes of the storytelling. And I think that's possibly a luxury of chaplaincy, right? I mean, there's certain things, of course, I have to pay attention to, but and worry about and be concerned about, but mainly, I want the person to tell the story they want to, and then try to hook it up to what I know about them, what I've read about them, or some reality check, right? Or um, and so it's almost like making a work of art, you know, like what are the what are the paints and brushes and pencils that a person would need? And then once we get that story, is it possible to actually put any of it into action?
Right.
I mean, there's always some piece that can be, we have to take a little bit of a chance on, well, that there will be, right? Something that we can actually help put into action. And the phantom limb part, I think, is also really fascinating when you raise that. I mean, it's a very big piece of, amputees' lives, of this ambiguous loss, this loss that they can never really get over, can only get through. But to think about the whole lower half of your body being a phantom limb is really, it was quite a devastating image to hear. And to think about articulating those losses. Again, if she's willing and able.
And of course, there's a lot of resistance in
Sure.
her to doing those kinds of things. I mean, I think when we talk about rewriting the story and helping people identify the things that matter to them, there's a way in which that requires a certain amount of prescience, right? Self-awareness and the ability to think about oneself as a temporally extended being with a past and a present and a future.
Mm-hmm.
And, there are several ways in which Stephanie has a hard time doing that. I think, she's traumatized. And one thing that comes along with that is that you develop this sense that maybe you don't have a future, right? It might just cut off unexpectedly. And
as it already has, actually, time after time, although she says 50, right? So it's kind of a both and, really, really interesting.
Yeah. But why did she only say 50? I think, you really picked up on something important there. 50 is not that old, and
right.
You wonder whether she doesn't have a sense of that there's really nothing beyond that. And she doesn't see herself living a lot longer. But then too, she gets into what Freudians would call primary process thinking, right? She's just in the moment. She's consumed by appetites and sensations and emotions, and it's just this roller coaster. So, asking her to think about the future, about herself as a temporally extended whole is sort of like if I asked you to eat some soup while you're on the roller coaster, She just can't hold on to it.
Yeah, I think that's right. And so there has to be a different way to do it. I mean, I think we would want to hold her as this extended being, but have her live in this very present primary processing moment. And I don't know what that would look like. I mean, I think we're sort of working through this idea together, but I think there is a way to be in that moment of sensation and also imagine, well, here's another way of looking at it. Be in this primary moment of sensation and talk about what you were hoping for. So actually maybe taking into the past, like what were the things that you were hoping for? What were, right? So tell us who you were, right? Since at the moment we can't really get a sense of who you are, but tell us about, I don't know, the house. Tell us about the smell of the beach. Tell us, try to get some place, actual locations to build on. And I mean, I don't know that it could go to the future, but there's some value of bringing aspects of the past, the non-trauma parts. I mean, this would be where I would go.
Right.
And I don't know if it's possible to bring the non-trauma parts, right? Sometimes when I see a patient, they say, "Oh, I'm just hopeless." That's a perfect moment to say, "Oh, that's my pager, got to go." But in fact, to try to help them remember a time when they had hope, if they'll let you, right? So I don't know what it would be for her, whether it would be hope or possibility. I don't know. But like, what was there a time when you had a different view?
Yeah. we explore those things with her a bit.
Mm.
And um, my sense was that her past is kind of a minefield.
Uh-huh.
It was hard to find safe ground
Wow.
because things as seemingly innocuous as the color of the paint on the wall
Mm.
could remind her of awfulness
Right.
in a way that ended up being very destabilizing.
Yeah.
And there were times in her life that were better, I think, right, where she wasn't actively being abused. Unfortunately, I think a lot of that time she was intoxicated
Yeah.
and didn't really retain a lot of that as, as something constitutive of who she is.
Right.
Probably the thing that she held on to from her past most consistently was an attachment to her two children,
Mm.
whom she'd had before she became very severely disabled. But that was difficult too, right? Because
Mm-hmm.
thinking about them was pretty painful for her.
Okay. Okay. No, that's a really helpful distinction of the depth of how difficult it is to work with somebody who's really had so much trauma. Um, do we have a sense? Do you have a sense of what keeps her going? I mean, that's like a fundamental making meaning thing, but without like tell me what gives meaning to your life. Like what keeps her waking up every morning when she's not having suicidal ideations or even when she is but not acting on them? Is there any from a again from a spiritual point of view, is there any life force that is can be tapped into?
Yeah, you're putting pressure on something about her story, which is um, maybe a little bit disingenuous on my part, right? Which is there must be something that's keeping her going because if there wasn't, she'd be dead,
Yeah.
right?
Yeah.
And I guess I'm not sure what that is. I think that it's possible that what she fundamentally wants is a sense of attachment and belonging and
Mm.
relationship, right?
Wow.
And
Right.
she's desperately hoping that she can get that somehow from a facility like mine, from someone like me, or
Yeah.
somewhere else. In fact, a lot of the time she talked about how she spent so much time in hospitals that people like me had essentially become her family,
Yes.
and how it was very painful to her to disappoint us by behaving in the ways that she sometimes would, because our opinion of her was like the only thing that mattered anymore.
Right. Right. And that's a devastating thing to hear. And some of that, is a little manipulative as well, of course. But when you hear it, it's such a cry for help. And I love what you said about, the fundamental need for connection, right? So when I was talking about some of the characteristics and how the human condition sort of persists, relationships. Not all of us make good choices about relationships, but we persist in connecting. And that's a sort of interesting thing too. So, from a chaplain point of view, where is she connecting? Where is she pulling something out? And I think that would be something that I would want to try to find. Um, is there is there a piece of resilience in there that pops out all of a sudden? Like, does she have any religious affiliation that you remember?
She was previously a member of the Church of Jesus Christ of Latter-day Saints,
Okay,
um, but is no longer.
right.
So I think culturally identifies with it in some ways, but isn't really um, a believer, maybe she would
Yeah,
say.
yeah. So the cultural part is interesting too. I mean, so many people have religious trauma at the hands of religious folk. That's also a minefield,
Yeah.
and something certainly in the hospital, and I'm sure every place else that chaplains work, we're always having to be on the lookout for. The person who is zealously religious or the person who just completely flips when they see a clerical garb or you say that you're a chaplain, right? And so to be able to try to gently see where is that spirit in her? Where is that life force? What does she call it? Right? When she's just sort of on her own. What are the cultural parts of that world that she still identifies with? I mean, it's enormously troubling and upsetting to be working in a situation where you can't get there, and I really feel that discomfort and tension.
Yeah. So
And yeah, go ahead.
I was wondering about the aspect of her suffering that relates to her institutionalization, right? And the way in which it's tragic that the only relationships she can sustain are via institutions. But I wonder what you, as a chaplain, think about how we might mitigate her institutionalization in some way. I mean,
Mm,
I see the
wow.
chaplaincy as although it is of and a part of institutions, separate from those institutions and what they
Yeah.
do in a lot of ways, right? Offering a different perspective.
Mm. Yeah, interesting. So I want to first let me just say, the relationships that she creates in these institutions. I mean, the one thing for me that stands out is that they're all temporary, and there's an aspect to that as well. Um, but how to make something non-institutional, boy, I sure don't know, because when she needs the kind of physical care that you have to have a certain level of institution, right? Could she manage in a group home? I can't imagine, but I don't know. Could she could she see her way? Could that be a goal? Could she see her way to having some control over her daily life existence? The choice of what she eats, for example.
Yeah.
Sometimes when I talk about helping patients remember who they are when they're not patients, I even go so far as to say, they're in the hospital and they're eating something they can't taste and they didn't order it. you know I mean, we're talking about, going back to your comment about the primary processing, about the sensations, is like, what is the smallest thing that would give her that sense of herself as a person? I think, institutions, boy, institutions do an amazing job, amazing work, and yet those of us who don't live in them think that they're a poor substitute for the lives that we have. But for some people, it's really stabilizing being in an institution. Um, I can't say that it isn't hers because of how many times she's changed institutions, right? But it organizes all these things that we wouldn't have to think about. But in her case, it doesn't seem to be providing any comfort.
Although
Um,
it's all relative. I mean, where would she be were it
right,
not
right.
for the institutions?
Right, absolutely. And that's my value laden version of, what do I think is providing comfort? No, you're absolutely right. You're absolutely right. I wonder, I, when I was thinking about how you even start a conversation like with somebody that we've been describing, I mean, where do you even start? Because we're sort of way down the road of, well, what are some other, sophisticated ways to think of it? But how do you even begin a conversation? a relationship with somebody like Stephanie?
Hmm. I I think that developing a relationship with Stephanie, which I'm going to concede was very difficult to
Mm.
develop and difficult to maintain.
Mm.
But it depended largely on trying to get to where she was and identifying her
Mm.
primary process in the moment kinds of concerns as they arose and validating them and doing things to the extent that the institution permitted it that address them. So
Mm.
she wants to take her medications at 6:30 in the morning. Okay. Well, the nurses don't typically give them until 7:30 or 8. We're going to try to make that work, right? And
Right.
bend a little bit here and there. And when we can't bend, say, we get that it makes it really difficult for you and it's upsetting. And unfortunately, there's just not a lot we can do.
Mm.
But maintaining the relationship with her is so hard because she is such a difficult and frankly, in some ways, unpleasant person.
Mm-hmm.
Um, right? Despite the fact that one wants to care for her and you can appreciate all the reasons that she has come to this point,
Mm-hmm.
sustaining that, kind of persistent positive regard for her that all the Rogerians want us to maintain is hard. The
Yeah.
countertransference is overwhelming. You should hear the nurses talk about her. It's
Oh
awful.
my gosh, it must be. It must be. I'm just thinking, that the resilience that you all have had to draw on for yourselves has been tested. Um, and also this sense you mentioned, I think, when you were talking before, this sense of makes you feel like you're not very good at what you're doing.
Hmm.
And that's one of those things that people can tear from us, right? And we realize just how fragile we are.
Right.
It's like, wow, it just took that one conversation. I've definitely had that, right? No problem. Absolutely. That one conversation just totally changed how I feel about how I do my work. That's crazy nuts, right? But it's part of how we're wired too. And it's not so much about empathy. I read a definition of empathy that was static. That you just you're sort of there. But that compassion is action oriented, not fixing necessarily, but action oriented, like meeting somebody where they're at. Or sounds like she sort of runs away, so it's hard to find where she's at, right?
Mhm.
But to think about the compassion part as being the walk with somebody, and that's very much the sort of the chaplain part of it. I mean, sure, we all develop our empathic skills, and some people are, better at it than others, but I think we're trying to, and I think in this conversation, we're trying to find a way to walk with somebody who it just has no idea. And what do we have to bring up in ourselves? Uh, Better way. What do we have to set aside in ourselves in order to take that walk? People, a lot of really smart people know how to push all of our buttons, and a lot of people who aren't so smart but have certain, psychiatric illnesses, right? Whether it's countertransference or they just know. And valuing the spirit of somebody, to cherish that spirit, even if it might be a little mean and unpleasant, right? And a little destructive, to value that it's there, very hard. Very hard. And yet I wonder if it's a gift to us as well as to the patient.
Yeah,
I don't know if you, yeah, good.
something you said there was really evocative for me,
Mm.
frankly. I feel like maybe the best we can offer someone in her situation is to walk with her to sit with her. But in order to do that, we probably had to set aside the sense that we should be doing anything else. And all of the expectations we have of ourselves that we can or should do those things if only we were better or smarter or tried harder.
I think that that's exactly what we're talking about, and this is sort of at the heart of chaplaincy is for all that most of us in the world are fixers and want to fix. It's the one thing you can't do as a chaplain. And it's the one thing that most of us, I think, who are chaplains have to really step away from. In that moment, as soon as I get home, I'm like, we got to fix this, right? But in the patient room, in the environment of the patient's world, this fundamental understanding and belief that the most that is possible is to take a few steps on the path. And I will tell you that having been a doer and fixer, I find it a relief. I don't have to make chart notes. I don't have, I'm not reimbursed, right? It's such a different format than what you're working in. But there's a piece of us that is very similar.
Right.
Right? So what are the ways when you talk about values, right? I think you have to pay attention to your values as well as a patient's values. And I wonder if there's ways to use your values appropriately to walk with somebody.
Mm-hmm. Hmm.
I mean, it's a really deep, serious case, right? When we first talked about it, it was just horrible because it's a terrible situation. Terrible.
Yeah.
But it calls up so much, and clearly on both of us, right? Emotionally.
This is essentially a protracted therapy session for me about this case. Right?
Oh, well, and for me, because I'm like thinking about all this, and I'm sure you have this experience, right? Where, the things that attract us are usually the things that will heal us, right? If we only can figure out how, right? So there's some piece of this, and some piece of this strangely witnessed conversation, because we can't see anybody who's witnessing this,
Right.
That maybe opens a door for all of us when we meet a situation that is intractable.
Speaking of
So
those
opening,
folks, yeah, should we invite
absolutely,
some questions?
Yeah.
absolutely. So in response to stepping through that threshold and opening that door with you, Linda and Brent, thank you so much for opening the door for us. So we have some wonderful questions from the audience. One in particular is from Kay Okada. It really touching upon, what you mentioned, Linda, about shifting the narrative potentially for Stephanie. Kay writes, what are the needs expressed by the core of suffering? It seems like there is a force or an identity which is demanding Stephanie's attention and claiming her life. Whose spirit is there behind the force? Can she claim a different narrative to neutralize that demanding force to shift her life to another dimension?
Fantastic. Thank you, Kay. I think you should consult on this. No, you're right. There's some fantastic Buddhist work and stories about the different characters in our lives, the different archetypes, and I'm sure the Jungian stuff as well. But like who is that's speaking? And who is it that's so hungry? I mean, I can't imagine that would be some place that she would go, but you're absolutely right to think really out of the box existentially about the drives and the needs. Wow. Yeah. I don't know, Brent, do you have some thoughts on that?
Well, yeah, I guess I have maybe a different perspective on it. I'm maybe a little bit of a self-skeptic in a way, right? In maybe the same way Castle is. I think Stephanie just is sort of who how she lives and all of the things that she cares about and that go into her life. And so I think that the need expressed by her suffering is maybe this very primal need to have all of those things, right? To have relationships and goals and values and a sense of herself as having a future and a purpose. But absent those things, maybe there's not a lot to her yet, right? That's something that we're trying to build with her.
I mean, it is totally possible that there isn't anything more there, right? That everything has been so totally torn away from her and that she wasn't able to hold on to a shred of it. It's totally possible, which is a really devastating thing to think about. But it is possible. In which case, how do we support her going on? What are, like, for whose benefit do we support her going on? If this is the shell that exists.
Right. There's a way in which we have to act as though there's that self there, even if it has evanesced and it's not there right now. We can only bring it back by sort of willing it into being, maybe.
Yeah, wonderful. I love the evanescence part, because it may not have been torn. It may have simply, piece by piece, disappeared into the air. Yeah. Wow. Boy,
Thank you.
how many times have we willed into existence something in that person sitting across from us, right? I know it's there. Show me. Well,
So a separate question, touching upon what you both just shared, from Emily and David Hoffman. What can we conclude about Stephanie from the fact that she has not ended her life? To Linda specifically, should we support her going on?
Wow.
Yeah.
Yeah. Go ahead, Dave.
Oh, I was just going to say, I think that we have to conclude that there is a part of her that wants to continue. I don't know what that part is. Maybe it is a self, a spirit. Okay, I'm uncomfortable with spirit, I'll concede. But something in her that wants things to be different. Maybe it's something like animal instinct, right? It's primal. I also think it's important to acknowledge that even for somebody who is as distressed as Stephanie, thinking about suicide, it involves a lot of ambivalence, she wants to die and wants to live at the same time, and where she is on that spectrum between those desires changes a lot from moment to moment, largely in response to how distressed she happens to be, right? Whether things are going badly with the nurses, or with me or with my colleagues, or relatively well, right? What are the relationships like in the moment? So I think that in some ways she's still alive, and I should say she's she's tried to kill herself many times,
Hmm.
but she's still alive in large part because she's always skating on the edge of really, really seriously, wholeheartedly wanting to be dead.
Hmm.
There's something in her that keeps her going.
Yeah. You know, I've never thought about suicide as being an ambivalence. You know, I know it's often considered an impulsive act, but I think given the number of times that you say that she's tried, I suppose yeah, I mean, there is some ambivalence. Um, you know, my religious tradition and my philosophical bent is towards life. And it's grounded in this little tiny piece of text of God saying, I present before you life and I present before you death. Choose life. What I can't do is say whether the quality of somebody's life is what it should be or is best it could be. Or, and I hear it all day long about people making value judgments because they have to make decisions about quality of life. So yes, I do believe that there's somebody there, and that somebody deserves support. I'm interested in why I'm
So
being so hesitant about saying that, but it is it's how I feel strongly about it.
thank you for your honesty, Linda and Brent. Uh, Others in our audience are curious whether at this point Stephanie can potentially rediscover meaning or purpose in her life, thinking of Viktor Frankl. But also the converse, the topic of voluntarily stopping eating and drinking is something that's been widely explored here at past presentations at the Completed Life Initiative. And is she aware that she can stop eating and drinking? Would it be ethical to notify her of that as an option in some sort of neutral fashion?
Boy, that's a toughie.
It is, yeah.
I guess I am of two minds about that. So I'll just mention Peggy Batten and Peggy's talked here at the Completed Life Initiative before, have written a bit about aid in dying and psychiatric illness. And I think we have overlapping, but not exactly the same ideas about it. I feel as though it is theoretically permissible, theoretically ethical, but I would have such a hard time having that conversation with Stephanie. I wouldn't tell her, by the way, you could stop eating and drinking, and that would be a way to put an end to your suffering. Because I feel as though it would in some ways be in conflict with the role that has been assigned to me, right? As somebody who is supposed to sit with her and be her champion and try to help her get through this, as hopeless as that process might seem. And again, that's me speaking sort of as a clinician, right, on the ground. What would I do if she said, "Oh, I've heard of this thing," V said, and I could stop eating and drinking, and I'm going to do that now? I don't know. I think I would have to have a lot of conversations with colleagues about it. I run my ethics committee, so it wouldn't be really helpful to consult the ethics committee, probably. I'd just be consulting myself.
And that's another psychiatric diagnosis, so I don't want to go there, right?
Right. But I feel as though that is clinically, it's just a challenging thing to talk about with somebody in her situation. And, you know, I will also express skepticism about her ability to do it. She is not someone who can carry out or has shown herself frequently able to carry out such a difficult plan, where she would have to maintain the same approach to doing that over weeks, probably, to be successful. I'm not sure that she could.
Yeah. Yeah, I was thinking about the consistency required to be able to do something like that. And I just from what I'm hearing, doesn't sound like that's it. I mean, it's a fascinating question, right? You know, if you're actually giving the patient choices, right? Do we hold back some choices? Um, do we sometimes press too hard for other choices? Uh, do we wait for the patient to raise it? You know, I don't know. I don't know. I mean, I think that we have to let the patient lead. I don't think we have the requirement to help them find ways to end their lives. I suppose if somebody says, as Brent is saying, you know, I have made this decision and this is what I want to do. Can you help me sort this out, get this information, you know, things like that. That is a different situation, although one would want to be in consultation, of course. But I just think there's a difference. I don't know where that fits in the do no harm part of our lives.
Well, the question you're evoking, Linda, is really, is the provider influencing the patient to
Right.
make that choice?
Simply by
really,
putting it out on the table.
Mhm.
Yeah, you're
absolutely.
right.
And remember now, Stephanie is, if she's focused on anything, focused on pleasing providers around her.
Exactly.
How vulnerable would she be to my suggestion that this is something she should consider?
Mm-hmm. Right.
Pretty vulnerable, I
So
think.
that
Yeah.
vulnerability is actually raised in a really unique way by our next question from audience member Judith Cohen. She wonders if Stephanie sets up situations where she gets evicted to create some sort of liveliness in her life, because within her disorder there is so much predictability.
Mm.
Wow.
Yeah. People speculate about this, and I think what's probably true with Stephanie is it's not that she does things with the goal of getting evicted, because, like I said, she's actually smart, and she is concerned about being able to meet her material needs. But what does happen with her is that because she's so insecure in her relationships with people, me, the nurses at her nursing home, etc., she often finds herself doubting those relationships and maybe unconsciously testing them. Right? Let me stress the system a little bit and see how much I can bend it, how much I can push against this person, before they reject me, right? Her hope is I can push a lot and they're still going to stick with me. But unfortunately, that sometimes blows up in her face, and she pushes enough that people push back and say, okay, we're done. That's why a big part of being successful in caring for her, I think, is, you know, what I said earlier, persistent positive regard, trying to maintain that, trying to stick with her, even though it's challenging.
So I think from a spiritual point of view, I would want to look at it from trying to feel something. Right, so we know that the lower half of her body doesn't have sensation except for pain, right? Or some kind of discomfort, numbness. But, thinking about the will that she's exercising, some of it she probably can't help, right? The illness does some of that, okay? The psychiatric illness does some of it. But there's some piece of her that is continuing to exercise the will to exist, but also maybe part of this desire to have sensation, to feel things. And it's really, Judith, what a wonderful image, really, again, to think about that her condition is so sort of stably bad that she needs to mix it up a little bit. So to just take that idea and say, okay, I need to feel more. What do I do to feel more? To feel, I don't know, feel human, to feel who Stephanie is. I don't know a lot about that stuff, the kinds of things that happen with cutting and burning and harming yourself in those ways, except that I think I understand that in some cases people express that they find some emotional relief. And so that's what comes to my mind about some of the behaviors. And certainly in the hospital, I've certainly witnessed, I've certainly experienced people who are so numb to their life experience that they want to stir something up in order to feel alive. I don't know the level of deliberateness, right? And that's kind of an animal instinct too. Let me just go mess with this a little bit and see where it gets me. But I guess that's another piece of why I keep thinking there's somebody there.
What's really evocative for me is that there is a sense of institutional numbness, right? Her being kicked out so much, and there being this burden of liability, and that it parallels so kind of magnificently her own physical numbness.
Oh, you're so right. You're so right. That's a wonderful insight. We forget, right? We're told that institutions don't have emotions, right? And they don't have faces. But the reality is, right? I don't know, Brent, maybe you're not told that, but but they do. They have these personalities. Maybe that's maybe too strong a word, right? They have these ways of being that are perpetuated. I don't know what that is. But it's in just about every institution. There is the how we do it, the who we are, the kind of people that we want here, the kind of people we don't want here. Yeah, the institutional numbness, that's a big help, I think, in this also, right? Because the institutions that she's been in are one of the characters in the story.
Yeah.
Or multiple characters.
Well, and I think that, a big part of the institutional personality that bears on her experiences is its obliviousness.
Mm.
The institution has ways of doing things, and it can only do things in that way, right? With very little flexibility.
Mm-hmm.
So it's very Kafka-esque, right? She's wandering the halls of the court of justice and has no idea why or what she's supposed to do.
Right.
She's just following the signs that are set out.
Yeah. Yeah. And one could argue that that's actually how most of us live our lives, but with less trauma.
Yeah. I don't want to think about that. Okay.
All right, fine. Let's not think about that. Let's take another question.
Another question. Here we go. This one's from Timothy Quill. He's wondering, has she been asked her thoughts and feelings about why she has not killed herself? And then have the answer explored? What's that conversation been like?
Yes. So in fact, I know she has been asked that question, at least by me, because we did sort of take that approach with her at various points in her therapy, saying, it seems like you're ambivalent about this, and
Mm,
you're here and you're trying to get care, and you're asking us to work up your not quite fever because you're worried that maybe you've got
mm,
COVID or something that's going to kill you.
mm.
And so there must be a part of you that wants to continue living. And what about that, right? And then, tying that into a sense that there must be things that matter to her, things that she values, and how can we capitalize on that? Um, the difficulty with that ended up being that a lot of the time when she came up with a value, there wasn't any feasible way of enacting it. I would like
Wow.
to, yeah, I would like to have a family. Okay. Well, unfortunately, she didn't have custody of her kids and hadn't seen them for several years and wasn't even really welcome to
Hmm.
call because of all the drama and other awful things that had happened over the years. So there was a lot of blind alleys, really.
Mm. But let me just take up that idea. I mean, it could still end up in a blind alley, right? But so I really want to have a family. Okay, what does that family look like? Who's in that family? Would she be able to create something or recreate? If it's just like this is the family that I have, right? But what would that family be like? What would those relationships be like? I don't, I don't know if she has the capacity for that or the attention, really. But that's again, that's the sort of the part of me that's like, I don't need to be concerned about the truth aspect of it. I need to be concerned with the person being able to get their story out. Well, like, this is what my family would look like,
Mhm.
or this is where we would be, which would then perhaps give us some values that she might not have expressed as a value, but oh, I see. It sounds like, making breakfast every morning is of meaning. Is that something you'd like to do here? I mean, I'm just totally riffing on that, but I do think, and this is why I go back to there's somebody in there. Like, that's a really big thing for her to say, given her circumstances, right?
Yeah.
And on the face of it, it could be sort of like, well, that's a ridiculous thing to say. You have a family, right? Or you have a family and it's fallen apart. But another way to look at it would be to say, okay, let's imagine that. Let's make this play therapy, right? Let's pick the characters out. Let's see what that would look like. Now, where would that take us? I mean, we don't know. We don't know. But
Linda,
what
that articulates an idea that I feel like I've had glimmers of with her and people
mm,
like her, which is that, maybe the important thing when you're confronting all of her problems is not just the realizing, right? The actual being part of a family, but actually simply appreciating that I am the sort of person who cares about this kind of thing
mm,
and and learning to constitute herself in terms of those values alone, right? Without instantiating them in her actions
mm,
or without an expectation that she is going to be successful when she tries to do so, right? So
yeah,
you might think of it as prioritizing the becoming over the actual being, which is
absolutely.
an
Wonderful.
inevitable process, basically.
How interesting. Yes. And I would say, as a chaplain, that's the place that I get to live, is the becoming. Now, it's not always satisfying because sometimes I'd like to be there for the being, right?
Right.
But you know, the role that I'm assigned, as you said before, is this becoming, is this process. And I think one of the terrible things that we both live with is that when somebody leaves, right, like our connection is gone, right? No matter how challenging it's been, you know, here we are spending a fair amount of energy talking about this person. So I mean, I feel connected to her, and I know you do, Brent. And so to think about how we invest in people, and then we're experiencing a loss when they leave, that we continue to want to redress somehow. And there's a piece of that we're offering the patient in front of us too. Like, we don't say it, but this is the kind of person I am. I care about you because you're here and you're a human being. And I can only really technically care for you until you walk out the door, but you're still in me. I heard I have a psychiatrist colleague at the hospital who said, talks about the preservation of pathology, meaning people come into the hospital, they're sick in whatever way they're sick, they are healed, sometimes cured, and they leave the hospital. Well, where did that pathology go? Well, we're holding it. Right? It's like, that's true. That's part of the role that we've been assigned.
The conservation of
So,
mass. Sorry, Sarah, go ahead.
Exactly.
Yeah.
so Peggy Batten jumps into the conversation with
Oh,
a really, obvious question, but one of those that when I say it, you'll think, why haven't we thought of this before? But of course, not until now. What do you think it would be like to let Stephanie view the recording of this conversation?
ooh, I've thought about that as we've talked, Peggy.
Wow.
Yeah, and it would provoke a ton of anxiety for me. But I hope that at the end of it, she could see that we are being real about her situation in a way that exemplifies caring passionately about what happens to her. That's my hope.
Mm.
I don't know how she would actually respond.
Mm.
Actually, I could predict that. Probably not well.
Yeah, well, I would never even think about that, right? I mean, I'm pretty sure that somewhere in this person, somewhere in Stephanie is somebody who wants to be seen as more than the sum of her stack of problems. I'm not sure watching this, listening to this would give her that sense,
Mm.
you know?
Yeah.
Because we don't know definitively. Like we just are positing that this person is more than all of these things that are intractable. But that's a pretty great question.
So Therese Trebeul just made a succinct statement saying that this case presents a perhaps rare opportunity to reflect and help a person identify their own completed life. And at the Completed Life Initiative, we're always looking to how do we foster access to helping people learn about these types of questions to ask.
Mm.
And so I'm wondering, in the vein of Peggy Batten's question, whether there would be a way to educate Stephanie on the resources out there without perhaps you being personally involved, Brent, or with that potential of culpability.
So the question is, could Stephanie come to know about the options for treating her life as complete without us being involved and without her clinicians being involved? I think yes, except that she's so institutionalized. I haven't mentioned it yet, but after calling 25 or 26 nursing homes, the social worker did manage to find a place for her in a different state, it turned out. But I can't imagine that facility is going to ease her access to that kind of information, or that they would be comfortable doing it. So it would maybe require a degree of independence that she's not likely to realize soon.
That's boy, that's a problem, right? Because we're not actually providing equal access because there's things holding us back. Right? My opinion about life notwithstanding, to try to provide equal access to information, to provide justice, to provide use of resources. And the reality is that because somebody is so heavily institutionalized, she might not know how to find something. She might not see something on television or read something or hear about it. Is painful, actually.
One audience member, named Therese, mentions that she's in favor of you mentioning or sharing nuggets of this conversation with Stephanie. And Therese thinks that Stephanie deserves to know that her case has left people caring about her but still not knowing what to do.
Yeah, and
wow,
I think that's an excellent point. I think it would maybe be healing to have the sense that people had thought deeply about this and recognize that it has been hard for her and that her situation presents many very significant challenges, and yet still maybe hope that she'll find some resolution, whatever that might be, whether it's finding that her life is complete or something else.
I think that could be really interesting, right? Just to say, I've had that experience in the hospital where patients will say how valued they feel by knowing that the tumor board met. And that just is not something that ever occurred to me, to think that these however many number of people looked at the slides and the situation and really held this person in consultation had meaning. It didn't necessarily affect outcome, right? It was about this meaning making of somebody. The institution has a piece of it that is constructed to care about me in a way that I never knew. Yeah, it was
Thank you.
interesting.
There's a beautiful note from Kay Okada, someone we heard from earlier, in her questioning it, and she writes, Brent, you've been transformed by Stephanie's presence for sure, and what a great work of consistent presence you are, anchoring her where she is. also nowadays, unlike the time psychotherapy taught people to be neutral, quantum physics and psychiatry are realizing how intertwined and inter-influencing our existences are. And we cannot be neutral, cannot be non-influencing. I thought that was a really beautiful summary of what you've displayed, Brent, and sharing Stephanie's story today. And thank you, Kay, for writing that so beautifully.
Yeah, thank you, Kay. I think perhaps it gives me a little bit more credit than I deserve. My ability to stay entangled with Stephanie, right, in that quantum way you allude to, is tenuous, right? It's something I have to work to sustain because it's challenging. But I agree that it's an important goal to try to realize.
But this also goes to the becoming rather than the being.
Right.
It's a wonderful way to look at this. I mean, we are transformed by the people that we look after. And possibly transformed more by the challenging and difficult folk as we go on in our careers than by others. I don't know. I'm beginning to think that myself, right? Because it takes more of us to figure it out, right? We have to dig deeper into ourselves.
Yeah. Like I would tell patients, it's a challenge, but think of it as a growth opportunity.
Right. Absolutely. That's like chaplain speak. Tell me more. It's like it's like great. Like, okay, thanks. Right?
Yeah, exactly.
Wonderful.
Well, thank you for ending it on a joyous note. I'd love to bring the conversation to a close, and I want to thank all of you in the audience for coming through the threshold with us today, as Brent and Linda have opened the door to this beautiful conversation. And thank you to Linda and to Brent. Both of you are wonderful to sit and talk with today. So thank you so much for being here and bringing your insights and your heart. Thank you.
Thanks very much for having us, Sarah.
Yeah, thank you. Really, it's been a pleasure. Really.
Thank you so much.
All right.
I want to point everyone's attention to the fact that we are 2 down and 1 to go in the March Symposium. I'm going to share my slides here, and we have the third and final installation of our symposium for March happening tomorrow. So if you're on social media, please tag us, #CompletedLife. Here are the ways to find us. And tomorrow, the third session is on God and death. So it will be another riveting conversation with a reverend, a rabbi, and an Islamic thinker and philosopher, who all three of whom are just really wonderful, and it'll be an incredible conversation. So thank you so much again for being here. Be well, take care of yourself, and I hope to welcome you back tomorrow for session 3. Good night.